Analysis of existing policies is an important aspect of continually improving healthcare policy. This seeks to analyze the existing North Carolina Nurse Practice Act and offer suggestions for modifications along with a singular recommendation. Healthcare policymaking is a long and arduous process of developing the driving policies based on various stakeholders and ethics in the clinical setting. There are several stages to the process of making an effective policy: identifying policy objectives, formulating policy, policy adoption, and policy implementation. One key ingredient in an effective policymaking process is communication with appropriate involvement of stakeholders. In addition to identifying stakeholders, setting policy requires a view of the ethics of the clinical setting. Ethics identifies principles such as autonomy and oversight. In the changing demographics of the United States, moral codes are rapidly shifting, causing a ripple effect in the ethics in healthcare. Many of the influences on healthcare policy and ethics in the clinical setting have very old roots, while some influences are newer ideas. For example, the Hippocratic Oath, sworn by new physicians, involves beneficence and non-maleficence. Physicians swear to do no harm and have the patient's best interest in mind. The Hippocratic Oath has been around nearly as long as there have been physicians. Of late, healthcare policy has become more patient-centric, which switches the focus of healthcare policy from the medical community to a holistic view of the patient. Each of these factors, along with the identification of the stakeholders, both patient and institution, provide the framework for healthcare policy and ethics. And nurse practitioners provide increased access to healthcare, especially in rural communities. Currently, under North Carolina Nurse Practice Act, nurse practitioners are required to practice under a collaborative practice agreement with a collaborating physician. Essentially, this means that for a nurse practitioner to practice in the state of North Carolina, they must have a collaborating physician who provides oversight to the NP's practice. North Carolina does not allow full independent practice authority for NPs. In North Carolina, nurse practitioners are jointly regulated by the NC Board of Nursing and the NC Medical Board. The NC Nurse Practice Act was chosen for evaluation because it has a direct impact on the future of NP's ability to bridge the gap between supply and demand in healthcare. However, as the National Council of State Boards of Nursing explains, without regulations such as the North Carolina Nurse Practice Act, harm can occur from providers who are ill-prepared or incompetent. In 2010, Congress passed the Affordable Care Act. According to Cohen, Zamiti, and Martinez, under the Affordable Care Act, 20 million additional people are insured in America, providing these persons with access to health care. NPs are well positioned to increase the supply of health care in the United States. According to Engelhardt, only 3% of graduating physicians in North Carolina became primary care physicians in rural North Carolina. As a result, NPs have been hired in even greater numbers in rural communities to expand staffing and attempt to meet the ever-increasing demand. The stakeholders tied to the NC Nurse Practice Act are each invested for a wide variety of reasons. Stakeholders include the nursing practitioners, of course, as well as physicians, physicians' assistants, medical institutions, the patients, and their families. Physicians are key stakeholders for several reasons. Under the Collaborative Practice Agreement, nurse practitioners offer services to patients, while the collaborating physician, who never sees the patient and can be located elsewhere in the state, receives a fee. However, money isn't the only reason physicians are stakeholders. Some physicians argue because of their 4 years of medical school and minimum of 3 years of residency, they alone are qualified for full practice authority and should maintain direct oversight over NPs. Therefore, physicians are stakeholders from a safety perspective as well as monetary. Physicians' assistants and NPs frequently apply for the same job. However, if the North Carolina Nurse Practice Act were revived, it is possible that NPs would be eligible to apply for positions for which PIs would not be qualified. And finally, patients and families. As previously noted, a large population in the United States, and specifically in North Carolina, now have access to health insurance and thus to health care. As a result, patients and their families are searching for primary care providers who are accessible and local. According to Engelhardt 2018, recruitment of non-physicians such as NPs has improved rural access to health care. There are social factors which also address quality and care factors. In a recent discussion with Representative Yvonne Lewis Hawley, this author learned that one of the primary social factors affecting the North Carolina Nurse Practice Act relates to a lack of understanding in rural areas. Persons living in rural areas are typically undereducated and underserved. As a result, there is a belief that by being offered an NP-only clinic, they are being provided less than the best possible care. Rather than viewing an NP clinic as equal to any physician's clinic, it is sometimes viewed in those areas as second best. As a result, one of the social factors is a lack of education that an NP can make all the same diagnosis and refer to all the same specialists that a primary care physician would make and provide. But while this perception does not affect the quality care provided, it does affect the perception of the quality of care provided. And lastly, economics is a factor. In a recent study published through Duke University, economist Dr. Chris Conover estimated that North Carolina would save an estimated $433 million to $4.3 billion annually by modernizing the North Carolina Nurse Practice Act. One of the primary ways North Carolinians would save on healthcare is that NPs only earn 40 to 50% of what physicians earn. And here are three options for modifying the North Carolina Nurse Practice Act. One option is to remove the requirement for a collaborating physician and grant full practice authority to NPs. As noted in the previous section, removing the collaborative practice agreement would have a significant impact on the cost of healthcare in North Carolina, reducing the cost by huge proportions. However, physicians would potentially see a loss of their own income as a result of no longer receiving fees for collaboration. One negative aspect of this option is that under the Affordable Care Act, NPs are able to participate in accountable care organizations, but are not able to be assigned as an ACO and independently practice. As a result, even if NPs were granted full practice authority in North Carolina to provide care to the Medicare population, NPs would need to join a physician-led ACO. A positive aspect of full practice authority is that North Carolina would join the ranks of 21 other states in consensus for uniform laws regulating NPs. According to the National Council of State Boards of Nursing, the consensus model was published in 2008 and has been designed to provide uniformity to practice, credentialing, licensure, certification, and education. The consensus model will ensure that all NPs are trained similarly, receive equal certification exams, and are qualified to practice within the same scope of practice. A second option for modifying the NC Nurse Practice Act would be to require that physicians and NPs work together in the same clinic, rather than the physician being remote. Under this modification, physicians and NPs would take a more tangible team approach to healthcare delivery. One positive aspect of this option is that according to Richards and Polsky, a mix of physicians and non-physician providers allowed for the greatest willingness to accept new Medicaid patients. With the advent of the Affordable Care Act and the influx of persons with new health insurance, it is imperative that the supply increase to meet the ever-increasing demand. Because many of the newly insured patients are being insured through healthcare.gov, clinics need to be prepared to accept Medicare and Medicaid patients. A negative aspect of this option is that there are simply not enough physicians to serve all of rural North Carolina in each clinic. In the 5 years between 2010 and 2016, only 11 newly graduated physicians became primary care physicians in rural North Carolina. There is currently a shortage of health professionals in 300 communities within North Carolina, and that number continues to grow. Requiring a physician to be present in every clinic will increase the shortage and force some clinics to close. A third and final option is that of doing nothing. One could argue that under the current NC Nurse Practice Act, patients are being served and new clinics are opening. In addition, the current regulations protect patients, offer the best possible oversight, and provide high quality, affordable care to rural North Carolinians. A negative side of this option is that it does not address the growing needs of healthcare in rural North Carolina. A positive aspect is that it ensures that clinics without a physician present, but with a collaborative practice agreement, are able to provide care as an ACO to Medicare patients. This author recommends option 1 be endorsed as the best solution for modifying the NC Nurse Practice Act. Currently, the NC Nurse Practice Act denies full practice authority for NPs. By endorsing option 1, NPs would be allowed to meet the burgeoning healthcare needs and are well positioned to do so without oversight. NPs have worked as nurses in the healthcare system before and during school for their advanced practice degree. Many NPs have years of experience which newly graduated physicians do not have. Nurses who are at bedside and in clinics are training on the job while they are training academically. According to Varnum, NPs manage 990 million patients each year. In 21 other states, NPs provide this care with a full practice authority, delivering care autonomously and safely under the consensus model. The NC Nurse Practice Act has served the state well, but it is time for a change. With the advent of centralized certification exams, the move to doctoral prepared nurses, and consensus on education and licensure, the state of North Carolina and the healthcare population will be best served by modifying this act and allowing full practice authority. As previously noted, there is a negative side to full practice authority, which relates to NPs being recognized as an ACO and being a sole provider to Medicare patients. However, this issue is already being addressed at the federal level with a bill in both the House and Senate allowing NPs to be recognized and provide full health care coverage to Medicare patients. In the meantime, states which have granted full practice authority are working with NP-run clinics to assess them to join an existing ACO while still practicing independently. The first step towards modifying the NC Nurse Practice Act involves embracing current legislation to pass bills before the State House and Senate. These bills modify the NC Nurse Practice Act and provide full practice authority to all 4 advanced practice registered nurses. Another necessary step involves educating the public on nurse practitioners and the NP's ability to provide full primary care health care, along with necessary diagnosis, prescriptive powers, and referrals to specialists. Evaluation of the modifications to the NC Nurse Practice Act will be ongoing. Initially, the evaluation will consist of identifying if the Senate and House bills passed. From there, evaluation of NP healthcare, costs of healthcare, and availability in rural areas will continue. These areas of healthcare are already being continually evaluated. Thus, the evaluation of the success of full practice authority will simply be added to existing evaluation. One example of evaluation of the modifications includes continuing to identify communities with healthcare provider shortage and identifying communities where healthcare providers are increasing. In conclusion, the North Carolina Nurse Practice Act is a valuable public health policy which allows NPs to practice safe and effective health care. By modifying the NC Nurse Practice Act to allow full practice authority, NPs will be better positioned to reach new patients and expand health care to meet the ever-increasing demand.